Hello, welcome to your online lecture for spinal functional anatomy. I think I probably need to start this by just saying that the spine, if you don't know, it is one of the most complex regions of the body. And it's for that reason that, quite honestly, we in the class discussing this particular anatomical structure, I truly believe that in order to understand the way that the spine functions, that you have to understand the foot all the way up to the glenohumeral joint and the wrist and the hand. So now that you have that great understanding of those anatomical structures, we can now talk about the most complex anatomical structure in the human body, which is the spine. What you guys probably know about the spine is it contains a multitude of bones, joints, ligaments, and muscles. And those muscles and ligaments and bones all work together to allow our spine to move. I think what I find most fascinating about the spine is not only does it include those bones and those ligaments and those muscles, right? Those dynamic and static structures, but it also includes the largest neuro component, which is the brain and the spinal cord, right? And so when we look at these when we talk about the spine, a lot of times I think people just think, oh, it's bony anatomy. It's so much more than that. One of the things that I think is important as we begin to progress through the injury evaluation lectures is really this idea that injury to the spine, in particular to the head, is a medical emergency. And so we'll talk about that. But this is one of those times where death can actually occur to a patient, or a patient can become a quadriplegic or a paraplegic. And so it becomes important to be able to assess and to evaluate the human body. So in particular, the spine. So as we progress, I'm going to start with the bony anatomy first. What we know about the spine or the vertebral column. And so when I'm saying vertebral column, what I'm referring to is this structure here, is that it has or is comprised of 33 individual bones called vertebrae, right? And each of these vertebrae, as you can see them here, kind of sit on top of each other like a stacked effect. And so let's go ahead and dive deep into the bony anatomy. First and foremost, in the most proximal portion of the vertebral column, we have the cervical spine, or what I'll call is the C-spine. And that C-spine has 7 vertebrae in it. The next spine or middle spine is the thoracic spine, or I'll call it T-spine. And it consists of 12 vertebrae. And then we have the lumbar spine, which is the most distal portion of the vertebral column. And that lumbar spine is comprised of 5 vertebrae. And so you can see here, if you're doing your math, you're probably saying, well, Dr. Cosby, you said there are 33 individual bones, right? And if we do the math here and you're adding that up, that's 24 bones, right? Well, these 24 bones are what are classified as movable or as true bones. So in other words, when we flex or when we rotate, those bones are going to move in a direction or glide in a direction that would allow us to make those movements. But with that said, we also have 9 classified bones that are what are considered immovable. And those really, truly, honestly have to do with this complex here. So that's sacrum and the coccyx. So I just wanted you to know, I do know my math, okay? As we're looking at bony anatomy, I think it's important to look at curvatures of the spine. And so this image here is really placed into this PowerPoint for that particular reason. So what we see with the cervical spine is that it kind of curves anterior, right? So in other words, that spine is curving anterior. And so you get kind of like this inward effect or caving in effect on the posterior aspect of the spine. That is known as a lordotic curve. And it's these curvatures that really allow us, number one, to extend the neck or bring the head back to your back and to flex the neck. So in other words, it allows for a good amount of range of motion. As we progress distally and we look at the thoracic spine, which is here, right? What we can see is that the curvature changes. We move from a lordotic curve to one that is more posteriorly deviated, and that's a kyphotic curve. So we have a kyphotic curve in the thoracic spine, which is great. It's going to allow for a lot of spinal flexion to occur. Additionally, it allows for, remember we talked about that scapular thoracic rhythm. So for the scapula to articulate with that particular spine and allow for scapular movement. And then as we progress distally, we move back into a lordotic curve. So we can see that here in our lumbar spine. Again, allow for a lot of spinal extension, which is what we need in the lumbar spine. And then that sacrum, most of you, or coccyx, and coccyx, what we typically would call it is a tailbone. So that is the bony anatomy. The way that I remember it is, I think, how do I eat breakfast, lunch, and dinner? So our cervical spine has 7 vertebrae. I eat breakfast relatively early, so at 7 o'clock in the morning. T-spine has 12. We typically eat lunch at 12 o'clock. And then our lumbar spine has 5. So again, remember, in terms of the total number of bones in the actual vertebral column, that number is 33. However, we only have 24 movable bones in the vertebral column. Okay, as we move over to the right side of the slide, then what we're really looking at is the complex neural anatomy. It truly is what makes the spine such a complex region. Injury to the neural anatomy of the spine and or injury to the brain can certainly lead to catastrophic results in our patients. So it's important that we discuss the anatomy, the neural anatomy of the spine. So as we think about the neural anatomy, I think it's important to think about the spinal cord as a part of the central nervous system, and it's contained within the vertebral canal. So we'll talk a little bit more about that a little bit later when we're actually looking at the different vertebrae. But in essence, what you need to know is that spinal cord literally sits central within the middle of each of these vertebrae. It extends from the cranium, so you see that here, and it goes all the way down to about the first or second lumbar vertebrae. So right about here, if we're earmarking that. And then from the lumbar spine, what we essentially have are basically roots. So you can kind of see those here. We have the lumbar nerve roots, and then the sacral nerve roots, and they come together to create what's called the quada equina. Which is essentially in charge of kind of bladder and bowel control. Ultimately, what we have coming or emanating off of the spinal cord are 31 pairs of spinal nerves. So you can kind of see those pairs kind of coming off of the spinal cord. What we know about them is that we have 8 cervical nerves, so 8 peripheral nerves in the cervical spine. We have 12 thoracic peripheral nerves in the T-spine. And then last but not least, we have 5 sacral, 5 lumbar and 5 sacral. So 5 lumbar and 5 sacral nerves. And each of these nerves come off of the spinal cord and supply different muscle groups, right? And this is important because if there's injury to a nerve that comes off of the spinal cord, then we certainly could see decreases in strength in a muscle group, or an inability to move a specific muscle or a specific joint, right? We can see how we're already starting to think about the injury and evaluation component of the spinal cord itself. So as we progress into bony anatomy, I think it's important to kind of just discuss each of the different vertebrae and what their shape and role is in the actual spine itself. So when we're looking at this image, the top vertebrae, so this top vertebrae is going to be a cervical spine. This middle vertebrae right here is going to be a thoracic vertebrae. And then this bottom vertebrae is going to be representative of the actual lumbar spine itself. And what you can notice is that as we progress from a proximal position to a distal position, that the size and the shape and the girth, if you guys are seeing that, so size, shape, and girth are changing as we move from a proximal position to a distal. In other words, the vertebral body of a cervical spine is going to be smaller than that of a thoracic spine, and a lumbar spine is going to be a lot larger than that of a thoracic spine and cervical spine. And there's a reason for that. We know about the cervical spine in general, like I said, is it contains 7 vertebrae, said that earlier on. in the lecture, right? So it's going to contain 7 vertebrae, and it is probably the most vulnerable spine to sport injuries. So those of you that will be working with athletes, this is the spine that is most often injured acutely. We'll talk about chronic overuse injuries in the lumbar spine, but acutely it's the cervical spine that certainly is the most injured, in particular in our contact sports. So when we think about the cervical spine, like I said, 7 vertebrae exist or are housed in the in this particular portion of the vertebral column. And the first 2 vertebrae are a little bit different. And so they're called the atlas and the axis, respectively. And their main function in the body is really truly to support the head on the spinal column, number 1, and then to also work with or to permit cervical rotation. So our cervical spine, biggest role in general is going to be to allow that kind of skull to kind of pivot on the spine. So it's smaller because there isn't a whole bunch of load that goes across the cervical spine. So we don't need a larger body, right, to distribute forces and to distribute shock across the human body. That's important. This is where those curvatures kind of come into play, because as those curves flatten out, which certainly can happen in different patient populations, as they flatten out, more forces get distributed, and you might have a patient who's complaining of cervical headaches. Our next spine is the thoracic spine. As I said earlier, it consists of 12 vertebrae. And what we know about the thoracic spine is that it has a longer transverse process. And this is important because it's going to allow for, number 1, attachment of the thoracic vertebrae to the first 10 ribs. In other words, what we see here is this costal facet, which is an indicator that ribs 1 through 10 will articulate with vertebrae 1 through 10 in the thoracic spine. And this is important, right? When we talk about scapular movement, when we talk about thorax movement during breathing, right? That articulation of the rib with the thoracic spine is hugely important. What we know about this spine is there's very little movement of the thoracic vertebrae. We're talking maybe millimeters of movement that occur to allow for spinal flexion and spinal extension. Our largest spinal body is the lumbar spine. It's comprised of, we said, 4 vertebrae, and this is the largest and the thickest of the vertebrae, and the reason for that is several. Number 1, it is at the midway point between the lower extremity and the upper extremity, which means this is the spine where most forces will be distributed. So we have to have a wider body, right? That wider body, just imagine, is going to allow for greater force distribution and efficiency in force distribution. So that's why it's larger. The last thing I want to kind of draw your attention to are 2 items. The first one that you see here, kind of this, what we would call is like a spinal arch. These spinal arches are responsible for receiving the spinal cord. So it's where that spinal cord is actually going to sit. And then in each of the spine, we also kind of have, I'm going to try to be as efficient here. We also have these kind of little outlets, and this is where each of those 31 pairs of peripheral nerves are going to come out of as they arise off of the spinal cord, right? So nerves going to come out here, and supply the periphery. As we progress, like I said on the other slide, we have the vertebral arch, which is here. The vertebral arch is hugely important because it is what's responsible for protecting our spinal cord. Remember that spinal cord is going to sit right in here and it's going to get protected, right? So the spinal cord, as you can tell, is protected by bony anatomy. Yes, this is the most anterior portion of the spine, and it is the spinous. It is the spinous process. We also have these kind of lateral deviations, which are called the transverse processes. The spinous process is the bony prominence that you feel when you flex and bend over and touch your toes and you're palpating, right? You guys may have gone for a physical exam and the physician has made you bend over to touch your feet to check for what? Scoliosis, right? So essentially that's what they're doing. They're palpating that spinous process. think it's important to understand here that your transverse process and your spinous process are huge sites for muscular attachments. And I think that's important to kind of understand. The muscles are most often responsible for spinal extension, rotation, and spinal flexion, right? And some of those muscles include, but are not limited to, your erector spinae muscle group, your serratus posterior, yes, your quadratus lumborum, your multifidi, none of which you actually need to memorize right now, but you need to understand that these sites, right, are huge sites for attachments of the muscles of the spine. And as such, when you have a strain of a muscle, sometimes they're going to complain of pain on the lateral side of the spine, or even more directly on that posterior spinous process. In terms of ligaments, in terms of ligaments of the vertebral anatomy, it's actually pretty simple. There are two ligaments that are hugely important in vertebral anatomy, and those two ligaments are listed here, and they are the anterior longitudinal ligament and the posterior longitudinal ligament. And when we look at what they do, that anterior longitudinal ligament, which is here, is essentially going to limit spinal extension. And so by that, what do we mean? It means that if it weren't intact, we'd be able to fall all the way down to the ground, right? So it prevents crazy amounts of spinal extension. Can we still extend? Absolutely. But we're thankful that we have this anterior longitudinal ligament, which is going to prevent crazy amounts of spinal extension. And then the posterior longitudinal ligament is going to limit massive amounts of spinal flexion. Again, just think, we do have those contortionists who are allowed to go into more flexion extension, more than likely some laxity, right, in these posterior and anterior longitudinal ligaments. So as a whole, we've talked about bony anatomy, which I think is important to understand. We've talked about ligamentous anatomy very basically. And then obviously, you guys, there are other intricate ligaments throughout, but these are the most important anatomical structures that I think you should know as we dive deeper into the injuries of the spine. And so between each of the cervical, thoracic, and lumbar vertebrae lie a fibrocartilaginous intervertebral disc. And these discs, right, if we think about what their role is to kind of transmit forces or to absorb shock as the forces move up the spine. Each disc is composed of an annulus fibrosus, which you'll see here, and then also the nucleus pulposus. Yes, and so the annulus fibrosus forms the periphery, or kind of what I would say is like the protection of the actual disc. It's extremely strong, almost it's fibrous tissue. So there's not a lot of give, which is good, because what we don't want to have happen is for this nucleus pulposus, which is the center portion of the disc, which is the portion that gets compressed under pressure, which is the portion that will kind of like a water bed displace, so forces can be distributed throughout the rest of the spine. And just like the meniscus, right? Think about this, like the meniscus in the knee or the labrum in the glenohumeral joint, the disc is the major shock absorber, right? That nucleus pulposus is the major shock absorber for the spine. So we want to have a strong fibrous structure such as the annulus fibrosus, because we want that disc to be able to expand, right? But then also go back to its kind of nucleus-like structure, right? Expand with force, come back to its nucleus-like structure so that it can expand again as forces are being transmitted. What we see happening in disc injuries is that if there's compromise, right, to this annulus fibrosus, like a tear, for example, then guess what happens? That fluid is allowed to leak out, right? And so that displaced disc no longer comes back to become like a nucleus-like structure, and we lose the ability to absorb shock, which leads to obviously disc injuries. Could certainly lead to fracture of the vertebral body if the bone is now bearing that force. So we can see how important both the annulus fibrosus and the nucleus pulposus how important they are to spinal vertebral anatomy. As we progress, we've kind of already talked about the nervous system as a whole, but what I want you to see here is just the vast array of neural output that comes from, obviously from the brain itself, but then from the spinal cord. And then what we can see from the spinal cord is all of the neural outputs and how they're supplying the entire body. Are you guys tracking with me here? So injury to spinal cord here, right? Just think about that. Could lead to an inability of the patient to use their legs, right? Injury to the spinal cord here could lead to the inability of the patient's ability to use their arms and their legs. So this is why I say the spine is so complex. This is why I say we end with this, because if you don't understand the actions of these joints or structures and anatomical structures, then you certainly can't understand how injury to the spine could lead to dysfunction in any of the anatomical regions that we've talked about thus far in this class. So we're going to move into injury evaluation soon. And I think it's important just very briefly to talk about recognition and management of spine injuries here, because I'm going to, when I end this, I'm going to do an online lecture for cervical spine injuries. And as I said, cervical spine injury is the cervical spine is the spine that's most often injured in an acute injury, particularly in contact sports. So it becomes important for my athletic trainers, my coaches, my athletic directors who are on the sidelines to be able to recognize that a spinal injury has happened, and then be able to figure out how to manage it. So I hope when you progress to the online lectures for spinal injuries, that if nothing else, you get two things from this. Recognize that the injury has occurred and figure out how to manage it. Is it a call to 911? Is it a referral to a physical therapist or an urgent care? What are we going to do to ensure that the injury does not become life-threatening or catastrophic for our patients? So it begins here. We're going to end the lecture with this slide because I need you to start thinking about all of the injuries that can happen. So first things first, when we look at spine injuries, there's many different ways to kind of look at them. But what we know most often is this. Injuries to the spine most often happen either in a flexion moment or an extension moment. Certainly could happen with a rotation moment, just more rare. So when we think about injuries, we have to ask ourselves, number one, was it during a flexion moment? And if so, here are the injuries that most often happen. A muscle strain or spasm, a disc herniation most often is likely, could potentially lead to fractures, dislocation, and ligament sprains, right? So if a patient comes into our clinic and we ask them how they injured it, if they describe a flexion moment, you're already thinking one of these 5 injuries has happened. Does that make sense, clinicians? On the opposite end of the spectrum, if the injury mechanism occurs in extension, then you're thinking, okay, maybe that patient hurt the facet. Maybe they have a ligamentous sprain, potentially a stress fracture. And last but not least, we're going to talk about spondylopathies in our injury evaluation segment. So I hope that this was helpful. I hope that you have a better understanding of spinal anatomy, more to come on injury pathologies to specific vertebral families next.